Nasal intubation is a procedure where an endotracheal tube, or ETT, is inserted through the nose and advanced into the trachea. This secures the airway, allowing for mechanical ventilation. It is an alternative to oral intubation, offering advantages in specific clinical scenarios. Nasal intubation is often preferred in situations where oral intubation is difficult or impossible. This includes patients with limited mouth opening, facial trauma, or specific anatomical variations. Additionally, it allows for better patient comfort and tolerance, particularly in long-term ventilation. However, nasal intubation is not without its risks and challenges. The procedure requires a good understanding of nasal anatomy, potential complications, and techniques to mitigate them. Proper patient selection and meticulous technique are crucial for a successful outcome. In the subsequent sections, we will delve deeper into the indications, contraindications, and the step-by-step process of blind nasal intubation, equipping healthcare providers with the knowledge and confidence to perform this procedure safely and effectively. Nasal intubation is indicated in a variety of clinical situations where securing the airway through the nose is advantageous. One of the primary indications is difficulty with oral intubation. This can arise from anatomical variations such as a small mouth opening, limited neck mobility, or a history of head and neck surgery. Patients with facial trauma, particularly involving the jaw or mouth, may also benefit from nasal intubation. It allows airway management without manipulating potentially fractured bones. Furthermore, nasal intubation is often preferred for long-term ventilation. It offers increased patient comfort compared to oral intubation, as it avoids pressure on the tongue and oral mucosa. Other indications include procedures requiring an unobstructed oral cavity, such as maxillofacial surgeries, and situations where patient cooperation is anticipated, such as during awake fiber optic intubation. While nasal intubation is a valuable technique, certain situations warrant caution or completely contraindicate its use. Recognizing these contraindications is essential to avoid potentially serious complications. Active epistaxis, or nosebleed, is a significant contraindication. Attempting nasal intubation in the presence of bleeding can worsen the hemorrhage and make visualization difficult. Patients with suspected or confirmed basilar skull fractures should not undergo nasal intubation. The procedure carries a risk of intracranial tube placement in these cases. Coagulopathies or bleeding disorders are another relative contraindication. Nasal intubation carries an inherent risk of bleeding, which can be exacerbated in patients with clotting abnormalities. Additionally, severe midface trauma, particularly involving the nasal bone and cribriform plate, can make nasal intubation hazardous. The procedure can further disrupt the fractured structures and lead to complications. Finally, the presence of a nasal mass or obstruction, such as a polyp or tumor, can make nasal intubation technically challenging or impossible. In such cases, alternative airway management strategies should be considered. Blind nasal intubation is a technique for placing an endotracheal tube through the nose and into the trachea without direct visualization of the larynx. It relies on tactile and auditory cues to guide tube placement. Gather necessary equipment: endotracheal tube or ETT, stylet, lubricant, syringe, suction oxygen source, and airway adjuncts. Choose an ETT size smaller than what would be used for oral intubation. Prepare the patient. Position them supine with their head in a neutral position. Inspect both nostrils for patency and choose the larger one. Apply a topical vasoconstrictor and anesthetic to the chosen nostril to minimize bleeding and discomfort. Lubricate the ETT generously and insert it into the chosen nostril, advancing it gently along the floor of the nasal cavity. If resistance is encountered, rotate the tube gently or try the other nostril. Advance the tube until the tip reaches the posterior pharynx. Listen for breath sounds as you advance the tube. The sounds should become louder as the tube approaches the larynx. During inspiration, gently advance the tube through the vocal cords. If resistance is met, withdraw the tube slightly and try again during the next inspiration. Once the tube is in place, confirm placement by auscultating for bilateral breath sounds and observing for chest rise and fall. Secure the tube in place using a commercial endotracheal tube holder. Connect the tube to an oxygen source and confirm proper placement with capnography.